ಸರ್ ಸರ್
Hello.
sir. Yeah. Can you hear me?
ನೀವು ಡೈಕಾನ್ ಹಾಸ್ಪಿಟಲ್ ಅಂತ ಲಾಗಿನ್ ಆಗಿದ್ದೀರಾ? Change your name.
I'm changing my name now. No, I came out of Dicon Hospital.
Sign out, sir.
ನೀವು ಮತ್ತೆ ಡೈಕಾನ್ ಹಾಸ್ಪಿಟಲ್ ಅಂತಾನೆ ಬಂದಿದೆ ಅದಕ್ಕೆ.
ತೋರಿಸ್ತಾ ಇದೆ ಸರ್, ನನ್ನ ಹೆಸರು ಹಂಗೆ ಹಾಕೊಂಡ್ಬಿಟ್ಟಿದೀನಿ. ಚೇಂಜ್ ದ ನೇಮ್ ಅಲ್ಲಿ ತೋರಿಸ್ತಾನೆ ಇಲ್ಲ.
ಸರ್ ಮೋರ್ಗೆ ಹೋಗಿ ರೀನೇಮ್ ಕೊಡಿ, ರೈಟ್ ಕ್ಲಿಕ್ ಮಾಡಿ ರೀನೇಮ್ ಕೊಡಿ.
ಓಕೆ, ನಾವೇ ಮಾಡ್ಬೋದು ರವಿ.
ನಾವೇ ಮಾಡ್ತೀನಿ ರೀ ಸರ್, ನಾನೇ ಮಾಡ್ತೀನಿ ರೀ.
ರೀನೇಮ್ ಇದೆ ಬಿಡಿ, ಇಲ್ಲಿ ಮಾಡ್ತಾ ಇದ್ದೀನಿ.
ಮಾಡಿ ಸರ್.
ಇದು ಹಾಳಾದ್ ಬೇರೆ ಅಪ್ಡೇಟ್ ಬೇರೆ ಕೇಳ್ಬಿಡ್ತು. ಸರಿ ಆಯ್ತಾ ಈಗ? ನಾವು ಕ್ಯಾನ್ ಯು ಸಿ ಮೀ?
ಎಸ್ ಸರ್, ಪರ್ಫೆಕ್ಟ್.
ಈಗ ಐ ಕಾಂಟ್ ಸಿ ವಾಟ್ ಈಸ್ ಹ್ಯಾಪನಿಂಗ್ ಅಲ್ಲ?
ಯು ಕಾಂಟ್.
ಐ ಕಾಂಟ್ ಸಿ ಎನಿಥಿಂಗ್ ಅಬೌಟ್ ದಿಸ್ ಒನ್.
ಅಲ್ಲ, ನಿಮ್ಮ ಹತ್ರ ಮೊಬೈಲ್ ಇದ್ರೆ ಮೊಬೈಲ್ಗೆ ಲಾಗಿನ್ ಆಗಿ ಅಷ್ಟೇ. ಬೇಡ
ಸರ್, ಅದು ಇದಾಗತ್ತೆ, ಬೇಡ. Okay, so it is still 1:44, so we still have time. So I
Yes.
stop the video.
Yes, sir.
Right. Audio is on. Nanige main power bloody thing is the plug points are not working here.
Yes, sir.
Yeah, yavattu problem is sir, plug points. Trying other plug points. Let us see. Light barta illa illi. So I know the plug points are not working. Even though full charge is there, it's okay.
Service ಅವ್ರಿಗೆ ಮಾಡಿ ಫೋನ್ ಮಾಡಿ ಸರ್. ರೂಮ್ ಸರ್ವಿಸ್
ಮಾಡ್ತೀನಿ. ಇಲ್ಲ, ಸರಿ ಆಯ್ತು. ಇವಾಗ ಇಲ್ಲೆಲ್ಲೋ ಸ್ವಿಚ್ ಇತ್ತು, ಒಂದ್ ಸ್ವಿಚ್ ಎಲ್ಲ ಇನ್ನೊಂದು ಪಕ್ಕದ.
ಓಕೆ ಓಕೆ ಓಕೆ.
ವಾಟ್ ವಿಲ್ ಯು ಬಿ ಪ್ಲೇಯಿಂಗ್ ನೌ ರವಿ ಇನ್ ಇದು?
ಸರ್ ಈಗ ನಾವೀಗ ಇದನ್ನ ಬ್ರ್ಯಾಂಡಿಂಗ್ ಇದನ್ನ ಟ್ರೈ ಚೆಕ್ ಮಾಡ್ಕೊತಾ ಇದೀವಿ.
ಓಕೆ.
ಸರ್ ನಿಮ್ ಲ್ಯಾಪ್ಟಾಪ್ದು
ಏನ್ ಲ್ಯಾಪ್ಟಾಪ್ದು?
ಲ್ಯಾಪ್ಟಾಪ್ ಪಾಸ್ವರ್ಡ್ 5860.
5860. ಸಾರಿ, ನನಗೆ ತಲೆಯಲ್ಲಿ ಇಟ್ಕೋಬೇಕೀಗ. ರೈಟ್. Hello, mic testing. Hello.
ಸರ್ ಯುವರ್ ಆನ್ ಲೈವ್. ನಾನು ಈಗ ತಾನು ಲೈವ್ ಮಾಡಿದೆ.
Oh God.
ಲೈವ್ ಮಾಡಿ.
Request all to mute and speak, ma.
ಎಸ್ ಸರ್. ಇಲ್ಲಿ ಯಾರು ಮಾತಾಡಲ್ಲ, ಯೂಶಲ್ ಆಗಿ ಈಗ ಸದ್ಯಕ್ಕೆ ಮಾತಾಡ್ತೀವಿ ಅಷ್ಟೇ.
Hello, everybody. It's 2:25, and we are about 5 minutes away from starting off probably the 12th edition of ADORE called 2021. ADORE 2021 is being conducted by the Cure Trust of Daikon Hospital in Bangalore, and it's a hospital trust which was formed in 2009 basically to take care of poor and needy patients. We started the Cure Trust to take care of the type 1 patients who are extremely poor. We were giving them free insulins and free tests, so on and so forth. And over the last 14, 15 years, the numbers have really grown. And in association with Primer Academy of Medical Sciences, we now have a total of about 2,500 type 1 patients whom we are taking care of. Initially, this ADORE was started as a CME for postgraduates in the field of medicine and diabetology. Later on, we extended it to the senior level family physicians and the fresh physicians as well. And since the last 2 years, because of the COVID situation, it's been on a virtual platform. And in a way, it was a blessing in disguise because we could connect with some of our friends and KOLs from across US and many other countries to probably bring you the best of the speakers on a virtual platform. Cure Trust has been working with free treatment camps in the slum areas for several years. Needy patients, elderly patients, retired people. In fact, 2 years ago when the COVID hit, in association with Diabetes India, Cure Trust and Diabetes India came together, and then we did a lot of work during the COVID times. In fact, we distributed free ration across Karnataka and even the border cities of Andhra Pradesh. And I must thank my friend and colleague, Dr. Sanjay Reddy, who took the initiative on behalf of Diabetes India to actually take the ration, to arrange for the ration, and to give it to the poor and needy patients. So 2020 was a very eventful year in terms of COVID, and we were extremely happy that we were able to do some service. And right at the beginning, I would like to thank all the sponsors of the ADORE 2021 virtual meet, without whose help this kind of a meeting is not possible at all. We have structured it as 2 different programs. We have Hall A and Hall B to start with, where we have the pharma symposias, where the pharma companies would like to actually showcase their particular drug, and what is new in that particular field is going to be discussed by experts. And you will start to listen to them very, very shortly. I will not be coming in the way of you, and of course, the excellent speakers. And from 5 onwards today till about 9 o'clock, we have speakers from US, the best in research and best in practice, who have done a lot of work, and they will be talking from their heart out, very passionate lectures starting at 5 o'clock with Dr. Rohit Kulkarni. In fact, last year, ADORE, we had our partners as the Chicago University partnered with us to actually take this program even to US. So the whole idea is to relax and learn. And I request all the delegates who are watching this to ask as many questions as possible. Put it in the chat box, and we will actually be taking it to the speakers. Now, I will be signing off. I thought I should say hello when we start. And I will now request our MC, Dr. Anita, to actually unmute her camera and then introduce the chairperson of this first session. Over to our MC and over to our IT room to take it forward from here. Thank you so very much.
Yes. Yes, doctor. Yes.
Dr. Anita will have to unmute herself, switch on the camera. And I would like to see the slide of the chairperson who is going to be introduced by her first.
Sir, good afternoon, Dr. Jayashree here. Hi,
Hi,
Dr.
Jayashree.
Arvind.
Hi, Jayashree.
Should I just go ahead and
We'll go.
I'm just waiting because we're all sitting in different places across
know.
Bangalore, and they seems to be having some kind of a problem. And then I'll just give them. That's why we started a little earlier. Okay.
Good afternoon, one and all. This is Dr. Anita here. Let me take the pleasure of introducing Dr. Jayashree Gopal, who's the first moderator for the session. Dr. Jayashree Gopal is a diplomat of American Board in Internal Medicine, Endocrinology and Diabetes. She is a director, Diabendo India in Institute for Diabetes, Endocrine, Metabolic and Lifestyle Diseases. She is also consultant endocrinologist and diabetologist, Apollo Hospitals, Associate Dean for Teaching and Research, MV Diabetes Research Center, Rayapuram, Chennai. Over to you, madam.
good afternoon? And I'd like to thank the organizers for inviting me here today. We're just about to, I think, kickstart the ADORE CME program. And again, a day of about very many practically relevant talks. The first topic discusses two sort of disparate and their clinical relevance, and the other is the of SGLT2 inhibitors and GLP-1 receptor antagonist. For the first topic, which is the role of a great pleasure into Dominic Benjamin, who has after finishing his MRCP and he's currently the head of the Department of Medicine and Geriatrics at the Bangalore Baptist Hospital in Bangalore. Also the Professor of Medicine for the International Medical School Bangalore campus of the Management and Science University, based out of Selangor. Dr. Dominic to talk to us about premixed insulins.
Thank you. Am I audible? Can I share the screen?
Yes, you are. Yes, you are.
Yeah, I just go. Sorry, I just go there. Thank you for the Cure Trust, and thank you for ADORE, and thank you, Chairman, for the introduction. Yeah, I think what is the heightened relevance of PPG and role of premixed insulin? Although we've been constantly being told that basal bolus is an ideal, which it is, and that's what we need to do. But I think practically, as you all will agree, that it's not pretty much possible. And also, we tend not to look at postprandial sugars, and we look at why postprandial sugars are so very important, and why that's so very important in Indian context, because of a lifestyle, the way we eat, the way we sort of consume carbs, and why premixed insulin, whether you like it or loathe it, or you just got to lump it, is that it is still very relevant, especially for Indian population. Now, one of the contents of my talk is we look at the unique characteristic of Indian type 2 diabetes patient. Unfortunately, we'll have a dubious distinction of becoming number 1. We are in number 2 in the number of cases. I hope we won't reach there. But we also look at risk associated with uncontrolled PPG by itself as an independent risk for cardiovascular disease and a whole lot of other things. We look at honestly insulin in Indian context. It's very good to talk and very good to talk about a lot of flowery things and use flowery words. But on the ground, how hard it is to start insulin, and how hard it is to convince patients about insulin, how hard it is to break the ice of starting insulin, and the prejudice that they have, and the false information that they have, and it's so hard to break through. And we also look at one case-based discussion, and there'll be a crisp take-home message. Now, how is an Indian type 2 diabetes patient different? In many ways, I lived in the Western world for 13 years, and I relocated back. The way they approach food is very different. The way they eat is very different. Food is more of a bringing people together. It's more of a fellowship than food. But here we look at food in a very different way. And food is something that brings us comfort. Now, this is a study called STAR study, which is published in Joshi and team in 2014. And they looked at the eating habits of type 2 diabetic mellitus. They want to find out how much of carbs do they consume, the simple and the complex carb. And it's pretty much shocking to see that they looked at the north and the east and the central and the west and the south. You look at it, in the south, there's 64% of their energy intake is from carbs, whereas in the north it's almost same, 33%, and in central it's 67%, and in the east it's 65%, and in the west is 61%. It's almost even Steven all across, with 60+%. That's pretty much high, very high compared to Anglo-Saxons. So data from the study showed that the carbohydrate constitutes about 64% of total energy from diet and type 2 diabetes, which is higher than recommended levels. Okay, there was a clear non-adherence to dietary advice in type 2 diabetes. So we are dealing with a population who want to consume a lot of carbohydrates. And how do you cope with that? Also, a lot of this public sector workers who start the shifts very early have what is called as a brunch. It's between the time between the breakfast and the lunch, and they consume a huge amount of carbohydrates. So we are dealing with a very unique set of population here. Now, we want to know, it's Monier et al. In 2006 and the team, which sort of mentioned that when your HbA1c is 7.3, 70% of contribution is from postprandial, and as it goes above 9.2 or 10.2, it comes at 30%, and fasting blood sugars takes more of the contribution. Now what we notice in the studies, which is mentioned here, at every HbA1c levels for Indian population compared to Caucasians or Anglo-Saxons, the contribution for HbA1c is significantly higher by postprandial blood sugars compared to people who are non-Indians or Anglo-Saxons or Caucasians. So as HbA1c increases, the PPG contribution increases in population compared to Western population comparatively higher. So what does it tell you? It tells you very clearly, if you want, of course, HbA1c is one of the markers that we take to make sure the sugars are, we want to make sure that the TIR is more important to make sure that there's time in range. But I think in the context that we have, in the resources that we have, HbA1c is a very important marker that we use. And we know that as PPG contributes a very significant portion of HbA1c, and we know HbA1c, the significant contribution comes from the latter part of 1 month before the 3 months what we consider. So I think as HbA1c increases, the PPG contribution increases in Indian population. So that's something that you need to bear in mind, and that will be a backdrop. Now, why are we so much perturbed and disturbed about postprandial blood sugars? So what we know physiologically is that once we eat a meal and within 10 minutes, your blood sugar starts going up. Normally, the beta cell secretes insulin, the alpha, it inhibits the glucagon. There is storage in the liver. There is decreased hepatic production. There's more blood sugars going into the muscles and adipose tissue to use it. But that is disturbed and perturbed in patients who are diabetic. So, and for the convenience sake, we decided that we'll take the blood sugars after 2 hours to see. Normally within 140 minutes, most of the blood sugars comes back to what pre-meal time. So in diabetics, it gets perturbed, although we continue to absorb the food that we eat over the 5 to 6 hours time. But so we know PPG by itself is an independent risk factor for macrovascular disease, increased risk of pancreatic cancer, increased risk of retinopathy, increased inflammatory markers, increased oxidative stress. It also causes increased early diastolic dysfunction, decreased myocardial blood flow volume, and increased cardiac intramural media thickening. So we know very well from the DECODE study and a whole lot of studies that has come out over a period of time that we need to take postprandial blood sugars very, very seriously. And uncontrolled postprandial hyperglycemia may lead to way array of complications. Now, this is an interesting study which studies PPG is an independent marker of mortality at any given fasting sugar levels. Okay, so it's an independent marker of mortality. If you look at the hazards ratio, at everything you see that postprandial blood sugars has got an increased risk of mortality. So it is so very important that we take it very, very seriously. Now, more patients achieve HbA1c by target by adhering to PPG target than FPG target. So this is a study which is published in Diabetes Journal in 2007, which shows that if patient is achieving FPG target of less than 100, 64% of them will be able to achieve HbA1c target. Whereas if somebody's got if the patients are achieving PPG target of less than 140, there's 94% more likely chances that they'll have a HbA1c control. So control of fasting hypoglycemia is absolutely necessary. I'm not dumbing it down. I'm not taking it away, but usually insignificant for achieving HbA1c control less than 7. As I mentioned to you earlier, we know that as the HbA1c comes towards 7, 70% of contribution for HbA1c comes from PPG. Control of postprandial hypoglycemia is essential for achieving recommended HbA1c goal. So what about the Indian context? We talk about what happens here. Are we starting insulin at the right time? Absolutely no. Disastrously poor in terms of the way we take time. It's about 9 years of your FINA study or on patients are languishing with multiple oral hypoglycemic drugs with a very high HbA1c. So intensive treatment of the OAD over a certain period of time has shown control, but eventually your glucose levels continue to rise. In India, insulin therapy is initiated only with HbA1c level at around 9. Well, we look at this across India, so it's sort of therapeutic inertia for initiation of insulin therapy still exists. It's very much there and it's very much alive and kicking. This delay may result in increased risk of diabetes-related complications. Hence, a timely initiation of insulin becomes imperative, absolutely imperative, for reducing the further risk of diabetes-related complication. Now, this is a study which showed that Indian data at the time of insulin initiation, they looked at the north, south, and significant numbers. And you see that across the board, HbA1c is about 9, fasting blood sugar is about 170 to 190, postprandial is quite high. And so we see that there is a delay in initiation of insulin therapy. So HbA1c is level about 9% at the time of initial insulin initiation across the 4 regions. And difference between PPG, breakfast, lunch, and FPG is about 80 to 100 across the 4 regions. There's often a delay in initiation, which results in a higher risk of failure of basal insulin. And another thing is, a lot of patients, I'm sure you'll know in your practice, that they come with so much of prejudice, so much of phobia about needles, and a lot of them thinks that once you start insulin, your one foot is already in the grave. So if you tell a patient that I'm going to start you on 4 times insulin, he'll be not only will he be absolutely mad, and he'll be absolutely petrified, but many times you can just start with one dose of insulin, that basal insulin, or a premix insulin. That's a better way to start, and much more likely that you will convince them. So convenience and simplicity with premix insulin is still very much relevant in India. It allows physicians to intensify the treatment with the same insulin. We could choose when there is a big meal they eat, and then we could still give them 1 shot of insulin. It does a lot of things. It breaks the ice. It takes away the phobia that they had. It also tells a lot of people whom I deal with, the older people, that they won't become hypoglycemic. Of course, there is a risk of hypoglycemia with insulin, but it's less likely. It's not as magnified as they think it is. So I think the whole lot of advantages with premix insulin as well. Now, there's a recommendation from global Indian guidelines on the choice of insulin regimen. It's the ADA and the other people has recommended basal insulin alone for insulin initiation, the NICE guidelines. Use of premix insulin apart from basal insulin for insulin initiation. RSS, DSI, and Australian and clinical practice of Malaysia recommend basal insulin, premix insulin, or insulin co-formulation for initiating insulin therapy. For goodness sake and God's sake, at least we start insulin and start talking early. And it's very important that treating physician sort of initiates it or has a intuition that this person may need insulin. Start talking to them a couple of visits before, so that you have a patient who is well aware of what you're going to talk, and it's much easier to convince. So this is a case study, role of premixed insulin in patients uncontrolled on OADs. And it's a hypothetical case. It's a 52-year-old lady, type 2 diabetes for 12 years, HbA1c of 9.3. In the last visit 6 months ago, typical as what we saw, most of them are HbA1c more than 9. Patient weight has been stable since last visit. Her weight was 74, BMI was 26. She is overweight, blood pressure 130/90, and glucose HbA1c is 9.3, fasting is 146, postpone is 255. And we'll see that UACR is 70 and liver functions are okay, cholesterol is high. Now, reason for the visit is blood sugars are not coming under control. She's on sitagliptin, DPP-4 inhibitors, sulfonylureas, biguanides, and other medications for blood pressure and a statin. She's a homemaker. She's a very social lady, so probably she must be eating and having meeting people and chatting. And a predictable diet with heavy breakfast and a dinner. And she's compliant with medications, and blood sugar has not been controlled. Looks like she's got a urinary infection and not adhering to lifestyle changes. So what do we do in these patients? Now, a factor to consider while choosing a patient-centric insulin regime. I want to emphasize this word, patient-centric. I think most of the doctors want to be doctor-centric, and it doesn't work. It's always good to take patients into consideration. It's all about him, and that he should be the center of things. If postprandial increment is more than 54 milligrams per deciliter, if FPC by HbA1c ratio is less than 20, if the difference between bedtime and the morning glucose insulin is more than 55, consider prandial insulin component through premix. The most important thing, which we tend to ignore, the psychosocial factors. The patient has limited literacy and unable to understand the complexities of basal bolus. It is simple and convenient option to start premix insulin. Adults at phase of life, adults at early progress or progress stage of disease, elderly patient need a very simple regime. Indian realities, if within limited resource, simple and easy to explain insulin therapy, it's better to start on a basal insulin or a premix insulin. And if the patient's on a high carbohydrate load, which most of my patients are, it's much easy and much more convenient to start a premix insulin such as Humalog Mix 25. They provide control of both fasting blood sugars and postprandial blood sugars, along with convenience of initiation, titration, and intensification. Now, this is a study which compares Humalog with metformin and glargine HS with metformin, and we clearly see that there is a reduction, and Humalog with the metformin brought about much higher reduction of HbA1c. Higher percentage of patients which premix insulin attain target in the postprandial area, but not in the fasting blood sugar compared to glargine and metformin. Well, there's always the fear, isn't it, that whether are they going to become hypoglycemic? The oral hypoglycemia rate was lower in both the groups, and we know that both of them cause hypoglycemia. I know that long-acting newer insulins are much less in terms of hypoglycemia, especially nocturnal hypoglycemia. And we see that hypoglycemia is much higher in a premix insulin compared to glargine. Come back to the lady, a socialite. She was started on Humalog Mix 25 10 minutes before breakfast. As we told, she has got a very loaded carbohydrate meal before breakfast and dinner. The dose was titrated at weekly intervals. After 4 weeks, second dose of Humalog 25 was introduced 10 minutes before dinner and 18 minutes before breakfast. A month later, she was stabilized. Insulin was stabilized at 22 units before breakfast and 16 units before dinner. And glimepiride was discontinued rightly. At 3 months, good glucose control of 7.5, which can get better. Well, we did talk about the importance of postprandial hyperglycemia, the contribution of postprandial hyperglycemia to HbA1c, the independent risk of postprandial hyperglycemia, postprandial sugars, and we also looked at the Indian population. They take more carbohydrates than normal. 60%. We also looked at the logistic on the ground reality of the difficulty of initiating insulin, the ease of using premix insulin for a big meal, and the challenges that we face, and also the dismal picture about how there's therapeutic inertia and the delay in starting insulin. To summarize, significant contribution of PPG even at high HbA1c in the Indian population as compared to Caucasians. Premixed insulins are simple to start with single insulin with effective HbA1c control, targeting both postprandial and fasting blood sugars. Patients uncontrolled on 2 or more oral hypoglycemic drugs with flexible lifestyle can be started on premixed insulin, and dose can be titrated on a weekly basis or much more convenient. Premixed insulin provide convenience and simplicity at initiation and titration, and especially for patients who are not well educated, who can't understand the complexities of it, it's much easy to start. Premixed insulin provides both convenience and efficacy to patients and contributes a long way in achieving glycemic control. I think I stopped there. Thank you, and over to the chairman.
Thank you very much, Dr. Dominic, for that very clear and crisp talk on premixed insulins. I think a couple of points that you made that I wanted to reiterate. One is that, as you pointed out, in our Indian population, a large burden, irrespective of the HbA1c, a large glycemic burden is because of the postprandial contribution related to a significant proportion of the carbohydrate content in our diets. And I always found it interesting that, as you pointed out, most of the, say, the ADA or the other guidelines recommend starting with a basal insulin. And those are all countries where if you fix the fasting, most often the postprandial would fall into place, not in our country. So it's, it's good that our country's guidelines always make a point of using premixed insulin, even when we initiate related to this carbohydrate load. And we'll take the questions at the end of the second talk, if that's all right. Or do you want to?
Tricky for me,
I don't
please.
see any. Let me just ask the organizers. Sorry, if there are any questions now, we can take it.
No, ma'am. Right now, there's no questions.
Okay.
Sure. Thank you.
Thank you so much.
Thank you. I'm sorry I need to leave. Thank you.
Okay, sure. Thank you so much.
Thank you. Thank you for the organizers. Thank you.
We move on to our second talk, which is the regarding the cardiorenal safety of the newer anti-diabetic agents, not only just the cardiorenal safety, but I would say the cardiorenal benefits of the GLP-1 receptor analogs and the SGLT2 inhibitors. And to deliver this talk, I have great pleasure in introducing Dr. Binayak Sinha. He really needs no introduction, but just to, just to make sure that we follow the rules. After finishing his MRCP, he worked in the UK and then returned. And since his return, he's been working as a consultant diabetologist and endocrinologist at the Amri hospitals in Kolkata. He is a very active participant in several international and national meetings also. Dr. Binayak Sinha, please welcome and please go.
Thank you, Dr. Jayashree. Thank you for your very kind words of introduction. Always a pleasure to meet, albeit online. I'll be sharing my screen now, and I'll be talking about cardioprotection in type 2 diabetes mellitus. Yep. Am I visible now?
Yes, you are. Yes, you are. Visible, audible. Thank you.
Okay. So this has become a very important part of the narrative of diabetes management now, cardioprotection in type 2 diabetes mellitus, and for good reason too, because diabetes and cardiovascular disease are integrally linked, because it is the leading cause of death due to across the world, and annual deaths due to CVD is 17.5 million across the world, and in India it's 2.5 million. So you can imagine how much India contributes to the annual deaths due to CVD. And not only that, diabetics are 2 to 4 times more likely to die from heart disease compared to those without diabetes. In fact, 80% of all deaths in diabetes is due to coronary artery disease or cerebrovascular disease. Not only that, this is a very expensive disease too. If a patient has diabetes and CVD, the cost of treatment is 3 times that of somebody with diabetes and no CVD. And a patient with diabetes and CVD, when you compare it to somebody who has no diabetes and no CVD, it is 7 times the cost. So it's a huge cost if a person with diabetes has coronary artery disease. Now, why do diabetics get CVD? There are simple things like, dyslipidemia, platelet activation, metabolic dysfunction, and environmental pollutants, which lead to diabetes and in turn also lead to coronary artery disease. And diabetes in itself leads to endothelial dysfunction with inflammation of the arteries and stiffness and oxidative stress. Now, what worsens this situation for diabetes is a sedentary lifestyle, a high-fat, high-carbohydrate diet, obesity, smoking, and all these conspire to make diabetes a happy hunting ground to develop coronary artery disease. And that is why diabetes and CVD is much commoner in Indians than in Europeans. And the time from diabetes diagnosis till first adverse cardiovascular event is significantly shorter, about 4.1 years earlier than the Europeans. Therefore, CV risk management, particularly in South Asian or Indo-Asian diabetic patients, demands an early aggressive approach. So there are two bits to this. One is the glucocentric approach, and then we will move into the glucocardiocentric approach of managing this diabetes. Now, as you can see, ADA recommendations say that in patients with established heart disease, the HbA1c need not be too strict. It should be moderate of the range. A modest glycemic control is good enough as recommended by the ADA. But we also know that diabetes improves, the endpoints of diabetes improve when you reduce HbA1c even by 1 percentage point. There is a reduction of 14% of MI, 14% of all-cause mortality, and any death or any diabetes-related endpoint comes down by 1/5. This is from the UK PDS, obviously. But then one thing that comes out from these two slides is that glycemic control is important, but not that important. You have to get good glycemic control, but let's not put too much stress on that point. As long as somebody can get HbA1c within 7 to 7.5 or 7.7 even, I think the risk of macrovascular complications comes down. But cardiovascular risk in diabetes continues to be present, irrespective of glycemia. And recently, the ESC has been able to classify patients into okay. So 3 groups. They are moderate risk, high risk, and very high risk. So obviously, patients with very high risk are patients with diabetes and established CVD or other target organ damage. Like, for example, a patient with diabetes who even has, say, a retinopathy is a very high risk for a cardiovascular event. The diabetic patient who has 3 or more major risk factors, for example, diabetic with hypertension, dyslipidemia, and a smoker, this becomes very high risk, or type 1 diabetes of long duration, which probably isn't a part of the discussion today. But we can imagine that a large portion of our patients, in spite of not ostensibly having any kind of very high risk potential, are actually very high risk patients. And what compounds the matter is the high-risk patients are any patient with diabetes more than 10 years. And I haven't shown you the data, but we have shown recently that Indian patients probably are high risk, even with 5 years of diabetes and more than 45 years of age in males and 55 years in females, even without target organ damage and any other additional risk factor. So now this is our garden variety diabetes. Most of the diabetes patients that we see actually have diabetes and hypertension. This in itself constitutes high risk, and we should be really careful about this whenever we are assessing patients' cardiovascular risk. A patient with moderate risk, a diabetic patient, as you can appreciate from this slide, is never low risk. A moderate risk patient is somebody who's less than 50 years, probably 45 in Indians, and diabetes duration less than 5 years in Indians, 10 years, which is the recommendation from ESC, without any other risk factors. I think this group of patients you will be very difficult to find in your clinical practice. Now, most anti-diabetic drugs have no effect on CV risk, like metformin, DPP-4I, sulfonylureas, or insulin. Pioglitazone, put a bit of a query because I am always a little careful about classifying pioglitazone as a drug which reduces CVD risk because it is so strongly associated with increased risk of heart failure. GLP-1RA and SGLT2 inhibitors have indeed been a boon to both patients and doctors who treat diabetes. Now, what are the results with the newer drugs? So this is with the DPP-4 inhibitors. We know for a fact that CVOTs with DPP-4 inhibitors have shown DPP-4 inhibitors to be completely safe in times of reducing major adverse cardiovascular events. SGLT2 inhibitors, they also reduce MACE, but we will come to this in a little bit more detail. I'd like you to focus on the dots. As you can see, there are only 3 dots which are really to the left of unity. And this is with EMPEREDGE, the CANVAS program, and the CREDENCE program. The DECLARE to me or the VERTIS have the dots to the left of unity, but the horizontal line crossing unity, which means they are not significant. So though a combination assessment of the overall MACE, when you look at all the CVOTs with SGLT2 inhibitors, seems to be indicating that there is some degree of benefit, but it is entirely driven by empagliflozin and canagliflozin. GLP-1 receptor analogs, however, provide benefit if you look at any of the GLP-1 analogs which arise from the human GLP-1 backbone. So you look at liraglutide, you look at semaglutide, you look at alpiglutide, you look at dulaglutide. All of them show benefit, and the benefit, even amplitude O is showing a huge benefit. The only things that don't provide a benefit are the ones that come from the other backbone, the exendin backbone, the ELIXA and EXCEL, which arise from the exendin backbone, do not show any kind of cardiovascular benefit. Not surprisingly, therefore, ADA 2021 recommendations, which is almost a copycat of the ESC-ESD algorithm, says that you should be putting patients with ASCVD or high risk of ASCVD on GLP-1RA or SGLT2 or both. And if one patient is on one of them, they should be starting on another. If the patients have heart failure, particularly heart failure with reduced ejection fraction, they should be on SGLT2 inhibitors, and DKD and albuminuria, they should be on SGLT2 inhibitors. And this is independent of baseline HbA1c and independent of metformin use. So these drugs have to be present. Now, this is completely independent of metformin use or any other drugs. You can think of glycemic control, because I agree glycemic control would be important in reducing the risk of retinopathy, infections, or neuropathy. But that would be stage B, and at that stage, you can add in other drugs. But the first line drug, if the patient has high risk or is very high risk or has established cardiovascular disease, you have to put them on GLP-1 or SGLT2 inhibitors. So this is what has been established very strongly by the ADA, and that you have to put these patients on these group of drugs, particularly in the presence of ASCVD or heart failure or chronic kidney disease. But are all the drugs same within these classes? And I think this is a very important slide. If you look at this, I mentioned this to you a little while back, you find that the MACE benefits are only seen with empagliflozin and canagliflozin. This is not seen with ER2 or dapagliflozin. What you also see is a 38% CV death reduction with empagliflozin, which is not seen with any of the other drugs that are in the market as SGLT2 inhibitors. Obviously, this makes these two groups of drugs more important for the management of diabetes and high risk or diabetes with established CVD. So empagliflozin, of course, is probably the best SGLT2 inhibitor because it reduces CV death in type 2 diabetes with established CVD and in high risk patients thereby. So in this situation, you cannot think of prescribing any, if you have somebody with established CVD or somebody who's at a very high risk of CVD, you have no choice but to prescribe empagliflozin. And if really pushed, you can prescribe canagliflozin, but dapagliflozin or artegliflozin will not be suitable in these situations. Again, if you look at the GLP-1 receptor analogs, the MACE benefit has been seen in all the ones which come from the human GLP-1 backbone, the liraglutide, the semaglutide, the dulaglutide, the alpiglutide. Alpiglutide, as you know, is not available in the market, and semaglutide in the parenteral form is still not available here in India. what again puts liraglutide ahead is the CV death reduction of 22%. So in patients with established cardiovascular disease, patients who are at very high risk, there is no choice but to prescribe liraglutide to reduce the risk of death in these patients. But so as the ASCVD, the ESC guidelines have pointed out, I think this is probably the hierarchy of prescribing it in patients who have developed heart disease already. But there are a subgroup of patients who do not have heart disease. These are the patients who are at lower risk, the patients who are at high risk or moderate risk. These are the patients who can go for dulaglutide because dulaglutide has established evidence in patients without heart disease and without risk factors, which makes dulaglutide a bit of a niche molecule because you can prescribe it across the continuum of diabetes and also in patients who are just about to start developing risks or just at the beginning of diabetes. So this is a big advantage over the other drugs in which it is prescribed only in patients who have established and severe heart disease. So the next question is, do we combine the two of them? Of course we combine the two of them. It just seems a bit of a no-brainer. And though there is no absolute data combining the two, there is this retrospective data which shows that compared to sulfonylureas, an addition of SGLT2 inhibitors reduced the risk of cardiovascular endpoints by 24% in a trial on patients who were already on GLP-1RA. To summarize, therefore, diabetes and cardiovascular disease are common and they exist together and is high across the globe as well as in India. Indians are far worse with their heart disease versus Europeans. Thus, the management needs to be early and aggressive. We need to be prescribing SGLT2 and GLP-1RA in type 2 diabetes who are at high risk or at risk for developing CVD. And SGLT2 inhibitors and GLP-1RAs have taken this place completely, providing cardio protection across the continuum of CV risk in type 2 diabetes. There is also some emerging evidence that SGLT2 inhibitors, when combined with GLP-1RA, might be providing additive cardiovascular benefit. Thank you very much for listening to me, and I will take any questions if there are any.
Thank you very much, Dr. Sinha. Again, an extremely clear and lucid presentation. I'm not sure if there are any questions, but I have a couple, and maybe we have about a few minutes for discussion, so I'll lead. When I was in training, that was the time when sort of statins really entered the market, and we were all trained in the use of statins for people with diabetes. And I remember one of my professors telling me, just think of it this way, is if the person why is the person with diabetes sitting in front of me not on a statin? And so to drive home the point that every person with diabetes needed to be on a statin to reduce their cardiovascular risk. Do you think we are there yet with these newer anti-diabetic agents, particularly with the SGLT2 inhibitors? Are you starting to think of it like that as a statin?
I think I totally agree with you on this. You see, I am now of the firm belief that you really need some evidence or some kind of a proof that the patient has a contraindication to being on a SGLT2 inhibitor. You know, I appreciate GLP-1 might have problems, A, being an injectable, and B, being extremely expensive, particularly for the Indian market. But for a patient with diabetes who comes to see me, unless there is some overwhelming contraindication, I cannot think of any reason why they protect the heart, they protect the kidney. So much of evidence with non-alcoholic fatty liver disease. So, in every space where there is diabetes, the risk of complications is reduced by usage of SGLT2 inhibitors and GLP-1. So I think I totally agree with you that we now need to look for contraindications not to prescribe these drugs.
And maybe you can just sort of just list out your absolute contraindications for an SGLT2.
Really, I can't find any except somebody who's really frail and elderly and maybe having, blood pressure related problems, hypertensive, living alone, prone to fractures kind of a situation. Other than that, even GTIs, I think, are a very small contraindication. I don't know your experience, but the number of urinary tract infections like pyelonephritis, I don't think in my experience of SGLT2 inhibitors I have seen too many. So I think very, very little by way of contraindications. In fact, they are extremely well tolerated. I think this is something that we kind of had a bit of a misconception when we first started using it, that they might be causing side effects, but actually they are extremely well tolerated drugs and have wonderful reactions. I do find one thing, particularly because I practice in Calcutta and Bengalis are very weight sensitive. So I have a lot of people coming and complaining about the weight loss, though that weight loss is good, but a lot of people come and say, oh my God, why have I lost weight? But I don't know whether that's there in South India, but I think that is one thing that I tend to notice.
I completely agree. I think it's the fact that they tend to lose weight in the face, sort of, their buccal fat pad comes down and it leaves them looking gaunt in some instances. And the invariable complaint is that they've been told that they look ill or deathly. For some people, it's a serious enough problem, even though we say, they get very upset about it. And then we have to either reduce the dose or spend a lot of time convincing them.
I think that is something that I find being the main deterrent at this point of time. Other than that, I don't see any kind of thing for not prescribing SGLT2 inhibitors. So
another sort of question somewhat related to this is, how soon after the diagnosis of diabetes do you consider using the SGLT2 inhibitor? I know we all think of it earlier and earlier.
I tend to start off as I would say there's no reason not to prescribe metformin. Metformin is cheap. We've had it for many years. It's a very good blood sugar reducing agent. So I think my go-to has now become a SGLT2 metformin combination right from the onset of the disease. And if the HbA1c is probably more than 7.5, I will probably go for a triple combination using, gliptin, SGLT2, and metformin if the patient can afford it.
Soon after diagnosis. And there was one other question that came up and so again, related to the practical aspect of the usage of the SGLT2 inhibitors, what do you do with the insulin and the sulfonylureas?
I don't know about your experience, Dr. Jayashree, but I think I have had a lot of people who have had a reduction in the doses of sulfonylureas and in the doses of insulin. But I'm not dramatic about reducing it right from the outset when I start them. I ask the patient to monitor, and if there's a problem, I reduce it. But I will go so far as to say that I don't know whether you'll agree with this experience, that the people who are on that that dose of 10 to 20 units of insulin per day, they are people who even come off insulin when you start them on SGLT2 inhibitors. And I think it's been from all aspects, it's been a real boon to patients with diabetes.
Absolutely, yeah. I think, like you mentioned, the frail elderly or the people living alone in whom I'm worried about a sudden hyper episode, I may consider either closer monitoring, particularly if they're living alone. And a lot of these elderly people with children abroad who are living alone may be in that situation, or if I'm worried about compliance, not going to return for follow-up. Probably in those situations, I would at least document, saying, reduce the dose or watch out for hypos and reduce the dose. But otherwise, if the sugars are very high to begin with, I don't necessarily we warn them, but we don't necessarily reduce the amount of. And since you mentioned the semaglutide and this GLP, I think it's a little bit off topic here, but have you used the oral form of the semaglutide?
I actually had about 2 patients in the clinical trial, so I think they were both on the semaglutide. So I still don't know.
They responded well as a clinically.
They responded. They lost weight. They had lots of side effects. So I think they were. So that's the only experience I've had. Did you have any patients in the trial?
I didn't have anyone in the trial, but I've had one lady who's, sort of spending an arm and a leg literally but getting it from the US because she wanted to try it.
Yeah.
Nothing that I did. And her uncle is a doctor in the US and she got it from there. She's been using it. So, and has had a good success as expected. I was a bit concerned about the oral tolerability, but she seems to be doing fairly well, at least on the minimal dose of it. On sort of the starting dose of the.
So I don't get me wrong. I don't think it's that intolerable. I think it's about the same as any of the other GLP-1 RAs, where initial part is a little bit of a stormy time. It's for some people take it very well. Actually, I think the people who are super obese actually don't have the side effects. This is my kind of observation. But these drugs are wonderful, even dulaglutide. I think the kind of results that you get, the kind of weight loss, the kind of glycemic control, people coming off insulin. I'm sure you've also had this example. People on basal bolus just going on to a basal. It's fantastic. It's just fantastic.
I think, and I think you'd agree with the GLP-1 receptor analogs, the preparation is key. If you tell them you're going to feel nauseous, you will have this, you sort of build it up to a little bit more than what actually happens, I think. Yeah. And then they say, yeah, like you said, doctor, but then because you built up the benefits and they start seeing the benefits, if they lost the weight, the sugars are better. And I think a very important aspect of it is also the reduction in the glycemic variability. So they feel far more comfortable because you've cut back on the prandial doses, like you said, and they're not constantly feeling hungry or having these hypo episodes.
And less monitoring, less, it becomes a more relaxed kind of life.
Absolutely. Particularly with a shot once a week with a dulaglutide. It's a big boon. It's a real advantage. Yeah. And I think just one final point I wanted you to comment on. The data regarding the retinopathy and GLP-1 receptor analog. Practically, what do you do before you initiate a GLP-1 receptor analog? What is the checklist before?
So I think one thing that I have started practicing, and I started practicing after a discussion with Dr. V. Mohan, and he had told me a story that, he saw somebody in his clinic who was a new patient of diabetes and said that come back to me after 3 months with your test done, and planning to do his screening at that point of time. And this gentleman came back with florid severe proliferative retinopathy and sued him, saying that, you should have checked me on day 1. So I have now devised a system where everybody who's in my clinic will have at least a yearly eye check. So though I think the side effect of progression of retinopathy with GLP-1 RAs at this point of time a little bit exaggerated, my patients will have an eye check in any case, whether or not they're on GLP-1 RA. I think it's more of a defensive attitude that I have taken as far as this complication is concerned. But to be honest with you, I have seen just one patient who was on liraglutide following a heart attack, incidentally started on the liraglutide by the cardiologist who developed retinopathy and came to see me saying that, could it be because of this? Kind of second opinion kind of a thing. But other than that, I have not had any experience of worsening of retinopathy or some kind of retinal detachment or vitreous hemorrhage following starting. Have you?
I have not either. And I think it's mainly related to the glycemic improvement. But again, just as a sort of more as a defensive practice, I would say I make sure they've had an ultrasound abdomen at baseline, or at least soon after starting or before starting, and an eye checkup, a documented eye checkup, at least in the last 3 to 6 months before I initiate a GLP-1 receptor analog.
I think that's safe medicine. I think that's safe medicine.
Any final words?
I think we've both kind of like discussed and established that these groups of drugs are the go-to drugs for the future of diabetes. Still, we have even further developments, the SGLT2 inhibitors, the SGLT2, SGLT1 inhibitors, the triagonists, the biagonists, all these things are also in the pipeline. So we look forward to this space so that lives of the patients with diabetes become easier and longer. And it makes life of the diabetes physician also more worthwhile. So I think we will look forward to this space.
Thank you. Thank you very much, Dr. Sinha. So we come to an end of the first session. We had the first talk on the usage of pre-mixed insulins and their role, particularly in controlling the postprandial hyperglycemia, and the role of the SGLT2 inhibitors and GLP-1 receptor analogs in terms of cardioprotection in people with type 2 diabetes. I shall finish up here and turn the session back to the organizers and Dr. Arvind. Thank you, Dr. Arvind.
Thank you, Dr. Jayashree. Hi, Arvind, how are you?
So should I take over, sir?
Yeah, there'll be an announcement from the MC. I think she's just ready to introduce you first way, then you take over from there.
Thank you, sir.
That's the key. Yeah, especially now. How do you think this is going to, just your opinion, I know I regard your opinion as one of the best in the country, so I would look forward to see how your thought process, what else do you be saying for? Yeah, 5 years ago, it would be a topic.
So that was a real knowledge treat for all of us. So we'll move on to the next session. I would like to introduce our moderator for the next session, Dr. Jignesh Ved. So Dr. Jignesh Ved has done his MBBS, MD Pharmacology. He's head of medical affairs, diabetes, Boehringer Ingelheim. And I would like to request Dr. Jignesh Ved to take over the session. Over to you, sir.
Thank you. Thank you so much, ma'am. And thank you so much, Dr. Arvind sir and the organizers of ADORE for having me here for this moderating this symposium. It's always wonderful to listen to the perspectives of Dr. Binayak and Dr. Jayashree ma'am. And this symposium is like an extension of the previous discussion on sodium glucose co-transporter 2 inhibitors on two relatively different aspects. As we talk of cardiovascular protection in the form of atherosclerotic coronary artery disease, this aspect is well recognized, but heart failure, as it is often conceived as the frequent forgotten, often fatal complication of type 2 diabetes. That's one aspect wherein SGLT2 inhibitors in the treatment of heart failure also have an important role in the current perspective. So that's one area that we'll be covering today in this symposium. And the other aspect is the use of SGLT2 inhibition in combination therapy for optimum outcomes in patients with type 2 diabetes, specifically looking at SGLT2 inhibition plus DPP4 inhibition in the context. So I'm immensely honored to welcome our experts for this symposium. The first speaker is Dr. Wing Commander, Dr. Shamana Sheshadri Iyengar, sir. It's always an honor, sir, to welcome you on for an academic discussion. Sir is an interventional cardiologist affiliated to Manipal Hospital. Very well recognized. Sir has been honored by with the Director General of Armed Forces Service Silver Medal and also bestowed with Vishishta Seva Medal by the President of India. Sir is also an examiner in DM cardiology with the Rajiv Gandhi University, Bangalore, Tamil Nadu University, Pune University, as well as Vellore University. It's my honor, sir, to welcome you for the first talk. And then following this, I'll invite Dr. Arvind sir for our second.
Good afternoon, Chairman, ladies and gentlemen. Thank you, Dr. Jignesh, for those kind words. I'll be talking about the place of SGLT2 inhibitors in the foundational heart failure care, when, how, and why. Now, definition of heart failure. Symptoms and signs of heart failure caused by structural or functional cardiac abnormality and corroborated at least by one of the following, that is elevated BNP or objective evidence of congestion. There's also some change in the stages of heart failure. Now, the new term has been introduced where we call it pre-heart failure. Just like we talk about pre-hypertension and pre-cancer, introduce this term pre-heart failure. And also, there is no such thing as stable heart failure because heart failure is never supposed to be stable. Either it is heart failure in remission or persistent heart failure. And with guideline-directed medical treatment, it could be reversed to some extent. Now, based on the ejection fraction, one has either heart failure with reduced ejection fraction when the ejection fraction is 40 or less, mildly reduced between 41 and 49%, more than 50% is called preserved EF, but most of the clinical trial take both these together as heart failure with preserved ejection fraction. And with treatment, there could be an improved ejection fraction. Now, heart failure is a progressive condition, and with worsening heart failure events, that is need for urgent treatment or visit to hospital or hospitalization, with each of these events, the cardiac function keeps going down and the risk of mortality increases. So the risk of mortality after worsening heart failure event treated in the outpatient setting in the emergency department or in the hospital is much higher compared to a person who has not had any worsening of heart failure. And what is the heart failure scenario in India? This is driven from registry of 1,200 patients, seen that after 3 years, the mortality was 44.8%, though the heart failure ejection fraction had a higher mortality as compared to the preserved ejection fraction. Now, what are the objectives of our treatment in a patient with heart failure? Apart from treating the underlying cause and comorbidities, we need to improve survival. We need to mitigate worsening of heart failure, need to reduce heart failure hospitalization, and improve quality of life. Now, let us look the role of SGLT2 inhibitors in the treatment of diabetes with these cardiovascular outcome trials. One was the EMPOWER outcome, where it clearly showed that there was 38% relative risk reduction in cardiovascular death in patients who had ASCVD and type 2 diabetes mellitus. This response was much better amongst Asian patients. There was 56% relative risk reduction in cardiovascular death in patients with ASCVD and type 2 diabetes mellitus. And death due to worsening of heart failure, cardiac shock, or sudden cardiac death was reduced by 44% in this study with empagliflozin. Looking at the dapagliflozin, it was not proved to be non-inferior with respect to MACE, but cardiovascular death or hospitalization heart failure was reduced by 17%. There was 47% reduction in the composite renal outcome and 27% reduction in heart failure hospitalization. Canagliflozin also showed reduction in cardiovascular death by 31%, and that is along with heart failure hospitalization. And heart failure hospitalization was reduced by 39%. So looking at these 4 major cardiovascular trials with gliflozins in diabetic patients, heart failure hospitalization was reduced by all these gliflozins, empagliflozin, canagliflozin, and dapagliflozin, but cardiovascular death was reduced only in EMPOWER outcome study. And MACE was reduced in EMPOWER outcome and CANVAS program. So the SGLT2 inhibitors do take care of pump, pipes, and filter. Now let us look at SGLT2 inhibitors in heart failure with reduced ejection fraction patients, that is ejection fraction less than 40%. DAPA-HF trial, where they included patients who were symptomatic, ejection fraction less than 40%, eGFR less than 30 ml was exclusion criteria. They looked at 4,700 patients, DAPA 10 milligram versus placebo, primary endpoint being worsening heart failure event or cardiovascular death. It significantly reduced the primary endpoint of worsening of heart failure or heart failure hospitalization by 26%, and number needed to treat was 21. We looked at the individual component of this primary endpoint. Heart failure hospitalization was reduced by 30%. Cardiovascular death was reduced by 18%. This was applicable to patients with diabetes or without diabetes. Patients with diabetes reduced the risk by 25%. Those who didn't have diabetes reduced by 27%. So apart from reducing the death and heart failure hospitalization and worsening of heart failure, it also improved the quality of life by improving the KCCQ score. Coming to the Emperor-reduced study, where they looked at patients with or without diabetes. GFR here it was more than 20 ml per minute per 1.73 square meters. 3,700 patients were randomized who had LVEF of less than 40%. And it clearly showed that it improved the heart failure outcomes. It reduced death or hospitalization for heart failure by 25%, the relative risk reduction, and absolute risk reduction was 5.2%. And number needed to treat was 19. And again, this benefit was seen whether the patient was a diabetic or a non-diabetic, patient was 65 years or less or more, whether the patient used the MRA at baseline, whether the patient was on ORNI at baseline or not. So all these groups of patients benefited with empagliflozin. And an important thing to note was the early benefit seen with this drug. The benefit, the risk reduction for mortality or worsening of heart failure was seen from day 12, an important thing to note. It also lowered the risk of serious kidney events in these patients of heart failure with reduced ejection fraction by nearly 50%. This is another interesting point. Its use was associated with a relatively lower risk of hyperkalemia in these patients of heart failure with reduced ejection fraction. If the patients were on, whether they were on mineralocorticoid receptor antagonist or not, both of them showed reduced risk of hyperkalemia. When they put these two studies together, meta-analysis that EMPER reduced and DAPA-HF, they clearly showed that the first heart failure hospitalization or cardiovascular death was reduced significantly. Cardiovascular death was reduced significantly. Heart failure hospitalization was reduced significantly. And all-cause death was reduced significantly. And when they looked at all the trials, that is trials done with the diabetic patients at cardiovascular risk and heart failure patients with reduced ejection fraction, 8 trials and nearly 60,000 patients clearly showed that gliflozins reduced all-cause mortality, it reduced cardiovascular mortality, it reduced heart failure hospitalization, and it reduced composite kidney outcomes. So SGLT2 inhibitors forms one of the drug classes for foundational treatment of heart failure with reduced ejection fraction. Of course, based on the individual treatment, we need to use the other modalities of treatment. Now, coming to the heart failure with preserved ejection fraction, so far it has been a sad story because hardly any drug proved to be very effective. So it used to be the heart failure with preserved ejection fraction used to be the single largest unmet need so far in cardiovascular medicine based on its prevalence, poor outcome, and the absence of clinically proven therapy so far. But there has been a breakthrough with the Emperor Preserve trial with empagliflozin, which confirmed a success story as far as the heart failure with preserved ejection fraction is concerned. Now, in this phase 3 trial, they looked at patients who had an ejection fraction of more than 40%. and whether the patient is diabetic or non-diabetic, and eGFR more than 20 ml per minute per 1.73 square meters. So there are 5,900 patients, EF more than 40%. So what it showed, it reduced the risk of cardiovascular death or heart failure hospitalization in patients with heart failure and ejection fraction more than 40%. The risk reduction was by 21%. Absolute risk reduction was 3.3%, and number needed to treat 31. When it looked at the individual primary composite outcomes, first heart failure hospitalization was reduced by 29%. Whether again a diabetic or non-diabetic didn't matter. Where the cardiovascular death was reduced by 9%, though it was not statistically significant. So in conclusion, in patients with heart failure and a preserved ejection fraction, the SGLT2 inhibitor empagliflozin lowered the risk of a composite of cardiovascular death or hospitalization for heart failure, mainly owing to a reduction in hospitalization for heart failure. Empagliflozin showed consistent efficacy in patients who had mildly reduced ejection fraction or preserved ejection fraction. I mentioned that heart failure with preserved ejection fraction means EF more than 40%. So they looked at two different groups. One group with 41 to 49%, that is the mildly reduced ejection fraction. Other one was truly period of ejection fraction, where the ejection fraction is more than 50%. In both these groups, death or hospitalization for heart failure was reduced significantly. And first hospitalization for heart failure also was reduced significantly. And again, this benefit was seen in both the genders. Again, whether it's a diabetic or non-diabetic, the benefit was seen. And the GFR, the patient had CKD or not, again, the benefit was seen. And whether the patient had AF or AT flutter, again, the benefit was seen in both the groups. Now, how about initiating SGLT2 inhibitors in hospital, those who are admitted with acute heart failure, de novo, or worsening heart failure? So this was a study where empagliflozin was initiated in hospital discharge in patients who were stable. Means they involved 530 patients with acute stabilized heart failure, including de novo as well as decompensated heart failure. This was regardless of LV ejection fraction, and eGFR, of course, more than 20 ml per minute. They were randomized to empagliflozin and placebo. So they saw that all-cause mortality was 4.2% in the empag group and 8.3% in the placebo group. Heart failure event, 10.6% in the empag group and 14.7% in the placebo group. So clinical benefit was seen in more than 36% more likely to experience a clinical benefit by those patients who received empagliflozin. All these factors were improved: time to death, heart failure event frequency, time to heart failure event were all reduced, and the quality of life improved. And one concern in acute phase for all of us is, particularly, is there going to be any acute kidney injury? Is there going to be hypertension? Is there going to be a problem of ketoacidosis? None of them had any of these problems compared to the placebo. So what is recommended by these authors who did these studies is that one should try to initiate day 1 to 4 of these patients who are admitted for heart failure with ARNI, beta blocker, MRA, and SGLT2 inhibitors. The focus being we should be on low starting doses, and we should prioritize beta blocker titration. And focus should be on complete set of quadruple medical therapy being implemented. If we're able to implement these 4 drugs right from the beginning, or at least all these 4 drugs in the first 4 weeks, it is expected that the more likely will be treated, more likely to tolerate these drugs therapy, more likely that there will be adherence to this therapy, and more likely that they will feel better, and more likely they will stay at home, and more likely they will survive. So all these days we have been practicing conventional sequencing in treating heart failure patients, going like step 1, step 2, step 4. And this usually takes pretty long time. Though these studies say 6 months, because in our practice it doesn't take 6 months, it may take about 2 to 3 months. But the concept now is instead of using sequential treatment, one should use all the 4 drugs in small doses to get the maximum benefit. And some of the sequencing suggested are, first step could be use of beta blocker and SGLT inhibitors. Because if you use SGLT inhibitors, there is no fear of hypotension or hypoglycemia or arrhythmia or change in the heart rate. So this is a safe drug to start off. One could combine it with beta blocker, but these 2 drugs together will reduce this risk of sudden cardiac death, what we see in the first few weeks after heart failure. Then one could add angiotensin receptor or methylation inhibitor and MRA. So by this way, probably we should be able to reach all these 3 steps within 4 weeks so that we get maximum benefit. There are some other mechanistic insights into these actions of SGLT2 inhibitors. This empagliflozin study showed that it significantly improved adiposity by decreasing the epicardial adipose tissue. It reduced the interstitial myocardial fibrosis. It reduced the aortic stiffness. It also reduced the LV end diastolic volume, LV end systolic volume, reduced the LV mass. It improved the ejection fraction. It improved the oxygen consumption. It improved the 6-minute walk, and it improved the Kansas City cardiomyopathy score. So SGLT2 inhibition exerts their cardioprotective effects through various mechanisms. Basically, they decrease cardiac preload and afterload by producing natriuresis, diuresis, by improving the myocardial energetics, by reducing the myocardial fibrosis, by reducing epicardial fat, by reducing neurohormonal stimulation, by improving endothelial function, and reducing arterial wall stiffness. And recently, they've also suggested that they found that by doing MR studies, they have found it increases the iron content of the myocardium, which correlates well with the improvement of the LV function. Then this study where they took the help of artificial intelligence, they found that empagliflozin could reverse 59% of protein alterations which are relevant to heart failure with preservation fraction pathogenesis. And the effect of this was mainly exerted via sodium hydrogen exchange inhibition, which reduces the stress and the inflammation. So heart failure treatment pathway reinforces simplicity with SGLT2 inhibitor use. It's a single dose, once daily, and no titration required. Now, what do the guidelines say? Now, European Society of Cardiology suggested that it should be used in heart failure patients. It should be used in type 2 DM and high cardiovascular risk, because risk of major atherosclerotic cardiovascular events is reduced by empagliflozin, canagliflozin, but risk of cardiovascular death and all-cause mortality is reduced by empagliflozin. And of course, the other drugs are also useful in reducing death and hospitalization by heart failure. It also helps in chronic kidney disease, the indications in type 2 diabetes with proteinuric diabetic kidney and induced type 2 diabetes and CKD. But we should be cautious about its use. The previous discussion we heard about some contraindications to SGLT2 inhibitors. I think these are the few contraindications I can think of mentioned here in the guidelines. Not approved for use in patients with type 1 diabetes. Of course, a diabetologist should be able to tell us better. Lactation, lady who's lactating, again, there's no data, should not use it. Patient on dialysis, we don't use it. Caution in patients, if you're using TAPA, eGFR should not be less than 30. If it's EMPA, it should not be less than 20. Pregnancy, again, one has to be cautious. The ACG, of course, sign says that these are the first-line therapies for heart failure, reduced ejection fraction, based on large randomized trials of heart failure with reduced ejection fraction, ARNI, beta blockers, aldosterone antagonists, and SGLT2 inhibitors are the first-line medication for all populations. Ensure that eGFR is more than 30 ml for DAPA and eGFR is more than 20 ml for empagliflozin before initiation. So all of us should become familiar and get fond of this fantastic four medicines when treating heart failure with reduced ejection fraction. This is an elegant projection study by Dr. Odinathan, which said that if you start using these four drugs in a patient with heart failure reduced ejection fraction at the age of 55, he will have 8.3 years of gain for event-free survival. He will gain 8.3 years of event-free survival if you start all these four drugs at the right time, as compared to the person who does not receive this comprehensive therapy. So that, in summary, why, how, and when of using SGLT2 inhibitor in cardiovascular medicine. Why? Because it has proven benefit across the spectrum of heart failure risk. We have seen the early benefit setting in the cardiovascular risk reduction as early as 12 to 18 days. There are no safety concerns and no monitoring is needed. And it has got synergistic effect with other cardiovascular therapies. How does it work? We have explained various mechanisms, basically by reducing preload and afterload of, and improving the myocardial energetics and improving the cellular metabolism. When to use? Should be used as a foundational therapy in heart failure with ejection fraction. First line in patients with ASCVD and type 2 diabetes. At hospital discharge if the patient is clinically stable, even in patients who are admitted with acute heart failure. And in patients with coma CKD, if GFR is more than 20 to 30 ml per minute per 1.3 square meters. We have to follow sick day rule that we avoid its use in acute severe medical illness, discontinued 3 days before planned surgery. We avoid using it in type 1 diabetes. We must counsel the patient in good perineal hygiene, and we must monitor the risk of these drugs. So SGLT2 inhibitors have grown well over a period of time. Thank you for your kind attention.
Thank you. Thank you so much, sir, for the short but very comprehensive perspective on the wealth of evidence that has been emerging today with these agents in heart failure. And with that, it's my pleasure to invite our next expert for the evening. And sir, of course, is the organizing member of the conference. Sir is the chairman, and Dr. Arvind sir is the chairman and managing director of Diacon Hospital. He is also the course director of postgraduate studies in diabetology and the visiting professor of medicine at PESI MSR Kuppam. Sir has been the past president of RSSDI, the general secretary of Diabetes India, and also the founder member of Diabetic Food Society of India. And it's always a great learning when we hear Dr. Arvind sir. So I welcome you, sir, to take the next session on the clinical excellence in cardiorenal metabolic care in type 2 diabetes, and with the perspective of SGLT2 inhibition and DPP4 inhibition in combination.
Thank you, Ved. Thank you so very much. I think if I'm allowed to share my screen now, that would be excellent. It's always a pleasure, of course, to listen to Dr. Iyengar, because we can always learn more and more when we actually listen to him. Thank you very much for being there, sir. So I think a good lot of empagliflozin has already been discussed, and my job becomes that much easier to be talking about the clinical excellence in the cardiorenal metabolic care of type 2 diabetes when we use a combination of an SGLT2 and a DPP4. And we know the love story between the diabetes, the kidneys, and the heart, and I don't have to really emphasize on the love story. We know how each other is actually affecting the one another. Many people ask us the question that I do see garden variety of diabetes? Do I really need to use this drug, which seems to be doing more for the heart and kidneys right on day one? Why can't I be glucose-centric? And to answer to that question, I will just put out this slide, which is the key take-home messages from one of the trials that we published in 2016 called the CINDI-2, which looked at young onset diabetes and the complications that they have on day one of diabetes. And we must realize that at diagnosis, under the age of 40, newly detected type 2 diabetics are seen with a HbA1c of 9.86, and it doesn't really stop there. 25% of them smoking, 27% hypertensive, BMI more than 23 in 83%, dyslipidemia in more than 60. And if you use the guidelines, 96% of young onset type 2 diabetics in India actually require statics. This was an eye-opener into 2016. I'm very happy that we were a part of this particular trial. And this is a recent study by Dr. Ramchandran's group, clearly telling us the profile of clinically diagnosed new type 2 diabetic patients. And then they have clearly shown the HbA1c at diagnosis is 9. And diagnosed during screening is about 8.3. That means already the ingredients necessary for a cardiac or a renal event is already boiling in these patients. So it's so asymptomatic. I and you may think that it's a garden variety of diabetes, but the cardiorenal issues are already present in most of our patients on day one. The earlier thinking was, of course, to go extremely slow, and there was a clinical inertia to start with more than one drug. In fact, we started with diet and exercises, then moved on to metformin, and then the second line, third line, fourth line. But things have completely changed in the last 4 to 5 years. We do know that every 1% reduction of HbA1c has great benefits, not just on microvascular complications, but also on macrovascular complications. And we also know that both SGLT2 and DPP4 do extremely well in the Asian patients. For some reason, we have always seen DPP4s doing much better in the Asian patients compared to the Western group of patients. And when we look at this particular slide, which talks about the different pathophysiological pathways which are there in the type 2 diabetes patient, there is effect on 8 pathways, what we call as the omnium actate, when metformin is actually added to the two combinations, that is empagliflozin and linagliptin. This is a very, very simple slide, and I've always liked this particular slide, which tells us the possible effects of combination on the cardiometabolic risk factors. Now, let's say we start with just a metformin. Well, it's powerful. There is an early efficacy, but it can't be the only drug that we can manage over a period of time. When you add another DPP4 to this particular drug, well, it's glucose-centric, low risk of hypoglycemia, probably no risk of additional weight gain. But when you actually add an SGLT2 to this combination, that becomes a very, very potent combination, because on one side, you have the blood pressure and the weight reduction. You have fantastic glucose lowering effect of this combination, almost no risk of hypoglycemia. And most importantly, we just heard Dr. Iyengar telling us the benefits of empagliflozin, especially on the cardiovascular and the renal parameters. And these are evidence-based and evidence-proved. And the number of clinical trials that we have seen over the last 5 years is absolutely mind-boggling. So I will not go into the details of it, but to importantly tell you that when you have a combination, a fixed dose combination, and if we can use that in clinical practice, you get a very early and robust reduction of HbA1c up to 1.8. And we know the evidence of empagliflozin with respect to the cardiovascular, heart failure, and renal parameters. And of course, there is very minimal risk of hypoglycemia and genital tract infection. And these are some of the graphs to basically tell you that when this FDC is used, what is the extent of the body weight reduction, the blood pressure reduction, and the reduction in the serum uric acid levels. And these are there already, and these have been discussed several times, but I'm just re-emphasizing the point that this combination seems to be working 360 degrees in reducing all the risk. And this is about the hypoglycemia that we spoke of, very minimal additional hypoglycemic risk. And another interesting part is because of this FDC and the addition of a DPP-4, for some reason, the genitourinary tract infections are lower because it is known the inhibition of DPP-4 enzyme present in some bacteria or fungi may lead to less infection. So when you add a DPP-4 to a SGLT2, we have always noticed, and now we are clear about why this happens, there is inhibition of the DPP enzyme, so your genital tract infections come down to a great extent. So this is the slide which Dr. Iyengar has already discussed, the CV and the renal outcomes with SGLT2 inhibitors, especially the empagliflozin. I don't have to emphasize its effects on hospitalization due to heart failure, CV death, C-point MACE, or the renal outcomes. Again, in terms of percentage, the amount of reduction that we see with CV death, hospitalization due to heart failure, etc. An important point to remember is a reduction in CV death was not seen in any other SGLT2 inhibitor in the CVOTs. And that's where your empagliflozin absolutely scores. And coming to linagliptin, it has ample evidence and is safe across all CV and renal outcomes. And especially the Carmelina clearly proved us that it has renal benefits, which we have not seen with any other DPP-4. In fact, in the Carmelina trial, the EGFR was actually low. There was a reduced kidney function compared to any other CVOTs to an extent of 62.3. That is the proportion of the patients with a reduced EGFR who were participants in this particular trial. So Carmelina also showed that linagliptin was associated with a significant reduction in albuminuria progression, and this was almost to an extent of 14% reduction. Now, here is a drug which reduces glucose, which does not cause hypoglycemia, which is renal safe, which is hepatic safe, now also telling us that it actually reduces the proteinuria progression by almost 14%. So we actually have a gold mine when we especially use this particular drug with an SGLT2 like empagliflozin. So these are the ADA EASD guidelines, and I don't really have to go into the details of this particular thing, but the important thing to notice is even the guidelines have now started telling us that the fixed dose formulations can improve medication adherence when the combination therapy is used, and it may actually help glycemic targets. And this is known. The less the number of pills, better is the compliance. And there's been enough studies with other drugs. So when you combine and when you have an FDC, which you don't have to increase or decrease, I think the adherence is going to be better. And especially if you have a drug which takes care of diabetes and the comorbid conditions, I think that is going to be a great combination. So we have the renal evidence from EMPA-REG and Carmelina. We have hepatic evidence, so you don't have to use any dose modification when you're using this combination of EMPA and Lina. And in patients with type 2 and NAFLD, EMPA significantly reduces the liver fat and improves the ALT levels. So we have discussed all the benefits of EMPA-LINA combination on the metabolic side, on the CV perspective, and the renal perspective. So from a glucocentric approach, I think now the world is looking at a very holistic approach of all our patients with type 2 diabetes by using this particular FDC. In fact, this has brought out a big change, because anytime when you're confused, you don't know what to give, if the patient can afford a combination, I think that would be the best drug to give. So the key take-home messages are, it's a very small pill, very easy to take, and there's an opportunity to combine two agents with complementary modes of action. Potential reduction in genital tract infections along with significant weight loss and a reduction in blood pressure has always been an added advantage. Earlier and more rapid achievement of glycemic target happens with this drug, and a potential to delay the disease progression and outcome of the clinical inertia. So with that, I will stop because we are running out of time. And then if there are any questions now, Ved will start taking the questions from this point.
Thank you. Thank you so much, sir, again for the short and very meaningful presentation on the topic. While we may await the questions from the audience, I ask one question to Dr. Iyengar, sir. Sir, now in the context of outpatient setting of diabetes care, the diagnosis of heart failure can be one of the aspects which may have some limitations. And would you like to share your wisdom on how to optimally approach screening for heart failure risk in patients with diabetes?
Yeah, in the outpatient setting of us cardiology OPD, diabetic patients come, usually ensure that he gets SGLT2 inhibitors unless, of course, it's a contraindication. And most of our patients go through the cardiovascular check, apart from the history, where we go through the history, the family history, the clinical examination, and the ECG, echocardiogram, stress test. So these are standard things we do for any patient who visits cardiovascular cardiology OPD. And particularly if it's a diabetic patients, most of our patients will be on metformin, because metformin, we are somehow historically and emotionally attached to metformin when we continue to using that. And all of them will have a diabetic patient and a cardiac patient has to have SGLT2 inhibitors. That's what we have made it a standard part of the treatment now. And yeah, that is basically, most of them get worked for. See, diabetes, many people still consider that is equivalent of coronary artery disease, though I don't believe very strongly in that. But to some extent it is true, but we need to investigate them for cardiovascular risk, looking at the apart from the ECG, echo and the biochemical parameters.
Sir, I have a question, if Ved allows me. How important is doing a pro-BNP in certain number of patients with probably diabetes more than 10 years or something, where the symptoms are very vague? Do you advocate doing a pro-BNP in all the patients?
Not as a routine. I think when you suspect that there is a possibility of heart failure, some of these symptoms may not be very typical. You might just say that I get fatigued, I feel tired. So that is, it's an expensive test.
Yeah.
The simple test I do is 6-minute walk test. And of course, when there is doubt, there are people who can afford, we should do the NT-proBNP, but not as a routine. Patient, no symptoms, we don't do it. He has to have his symptoms and signs or suggestive of heart failure, then we do it. And that is my priority. Don't do it as a routine.
Thank you, sir.
Thank you, sir. Dr. Arvind, sir, now one question for you in the context of your topic. The priorities for managing type 2 diabetes, in the immediate term, it is about risk factor management, but in the long term, it's also more importantly about target organ protection, preventing complications, which probably isn't, from the pragmatic point of view, how do you place the long-term priority, sir? And how would you recommend its approach?
I think this is a question that's being asked for quite some time now. You start early and then try to reduce the risk of CV and renal progression. And then you can actually save a lot of money over a period of time. And then you don't have to be, penny wise and pound foolish, and then try to save money right at the beginning. But then we understand it as doctors that treating long-term complications are extremely expensive, and then it drains the patient completely of whatever he has saved. But to make them accept an expensive tablet right at the beginning is also equally tough for doctors. So I think you have to weigh them, and then it's absolutely patient-centric. But what I have seen in India now is the DAPA going into the generic mode, a huge number of even the family physicians are now telling me that, okay, at last I can use this great drug in almost all my patients because it is now affordable. So I think India is a very price sensitive country. And even though we have great evidence with this EMPA and LINOC combination, I think price can be an issue in one set of our patients, but otherwise this has the best evidence, and these two are the best molecules in terms of scientific evidence. And in all affordable patients, we don't hesitate to use this combination.
Thank you. Thank you so much, sir.
Can I ask, may I ask a question?
Please, sir.
What is your experience? One is it's used in pregnancy and lactation, because one guidelines say lactation is contraindicated, other guidelines say both pregnancy and lactation are contraindicated. Second question is,
yes, sir. Now I can.
Urinary infection. Sorry.
I think I could not hear the last part of what you said, sir, but I could gather that you want to know whether it is contraindicated. Nowadays, what they're saying is even metformin is contraindicated. Even metformin is contraindicated in patients, who are actually breastfeeding the baby. So to that extent, we are becoming a little more careful because we don't have any clear evidence. And just to be cautious, and I have asked the same question to Dr. Sheshaya, who has done so much of work on GDM and diabetes in pregnancy. And he said, when we don't know, it's not good to take the risk. So especially if it's a pregnancy and then the lactating mother, he said, no, don't take the chance. Tell them to take insulin as long as they're breastfeeding the baby, which is more important, and they can definitely take insulin and be safe. And I don't think there'll be any trials, and this question will probably remain forever, sir.
I don't know about somebody develops the genitourinary infection while on SGLT2 inhibitors. Do you stop it once for all, or do you?
So right now we are telling every patient about the genital hygiene right at the time of giving an SGLT2. But some patients do extremely badly. In spite of following all the genital hygiene, they say, no, it was impossible to take this drug. In such patients, we are forced to pull them off the drug. So we do tell them that, okay, this is the drug which can cause this. So you have to take this drug off, and then you try to manage with the other drugs for them.
Thank you. Thank you, sir. Dr. Angus, my one last question for you. Now, elderly patients, this is again a specific group wherein we need certain clinical considerations, and both from the aspect of risk of heart failure, subclinical heart failure, the pre-heart failure population, as you mentioned, or even overt heart failure, which remains undiagnosed, and the use of SGLT2 inhibitors in the elderly population. What would be your perspective on that, sir?
Once you have a diagnosis of heart failure, or even a diabetes with high cardiovascular risk, I have no hesitation in prescribing to elderly individuals. Mm-hmm. And as Dr. Arvind said, again, we advise them the perineal hygiene, and we always tell the family members about taking care of them.
Sir, I have one quick question to you, sir. As a cardiologist, you see a patient with diabetes coming to you with heart failure. Orni becomes your first choice, or SGLT2, or you combine both of them at the same time?
As far as possible, before most of our patients now, before the SGLT2 came, they're already on beta blockers, they're on ARNI or ACE or ARB and MRI. All I have to do is just add SGLT2 in it. So we have to combine it. You get the maximum benefit with these four, what you call five classes of drugs, 5 classes and 4 drugs. These 4 drugs are a must. ACE inhibitors are ARB, but many of them we prefer change over to ARNI. So ARNI is one drug. Then he is a beta blocker. Then he was an MRI.
In fact, I liked your last slide when you actually showed that, when all the 4 drugs are used, the benefits are much better than any of the 3.
Yes.
Right. So thank you so much. On that note, I believe we have any last words, Dr. Arvind sir, from your side?
No, I just would like to thank the PI for this wonderful symposium, and then it's always a pleasure to be speaking on the same platform as Dr. Iyengar. And he has been a teacher, and way back, I go back to the late 80s when we were doing TGs, and then we would always go and listen to his lectures. So it's always a pleasure to be sharing the same platform with him. So thank you very much. I think with that we can probably end, and then ask the Master of Ceremony to take over and start the next session. I can already see Dr. Sattu smartly getting dressed up and ready there to take over from us at this point of time. Thank you, Ved. Thank you, Dr. Iyengar.
Thank you, sir.
Dr. With a pleasure to be.
Thank you, sir.
Thank you.
So that was a very informative session, sir, on a very elaborative and very comprehensive talk on SGLT2 inhibitors by our cardiologists as well as diabetologists. So now we move on to our next symposium. This is sponsored by Novo Nordisk, and it will be chaired by Dr. G.B. Sathur. So it's my pleasure to introduce sir. Dr. G.B. Sathur, he is MD, a physician and diabetologist from Sathur Medical Care, Hubli. He has done his MRCP from UK, FICC, and he has received Best Speaker Award during 17th International Cardiovascular Conference in Kathmandu, Nepal in 2019. And I would like to welcome Dr. G.B. Sathur to take over the session. Welcome, sir, and over to you.
Sir, you are muted. Sir, kindly unmute yourself.
Am I audible? Am I audible?
Yes, sir. Yes, sir. Continue.
Okay. Yeah. Thanks a lot, ma'am. It has always been a great pleasure. Thank you, Dr. S.R. Arvind. You have always been a tremendous drive for every guy practicing diabetes in this country, right from a person who has just passed his MD and also a guy who wants to retire from the practice. So congratulations, keep up your excellent work, and thank for this opportunity to all the team, the organizing committee, and to Novo Nordisk. We have got two speakers today, and Dr. Subhas Wangano is an extremely well-known figure. He is seen often on many platforms. He has covered a number of topics on diabetes. And this topic especially is my favorite because it has been coined so well: critical, but not yet critical, not critical, but yet critical. I mean, these situations are very common in a non-ICU setup. And the night duty doctor is invariably non-MBBS in some hospitals. At 2 a.m., he shifts this panting patient to the ICU because the blood glucose was 500 at that time. So I think Wangano has an excellent topic to discuss. How do we manage these patients who are critical, but who are not in a critical setting? I welcome him. He's a MD GM, has an FRCP, head of the Apollo Center for Obesity, Diabetes, and Endocrinology at Indraprastha Hospital, New Delhi. Dr. Wanganu, sir, platform for you.
Thank you, Dr. Sattu, for your kind words. I will start sharing my screen. I think my slides are visible.
Yeah.
Thank you very much. And thanks a lot for this Novo Nordisk sponsored symposia. Thanks to Dr. Arvind, the ADORE group, for allowing me to just talk on his fantastic every year, the scientific extravaganza he organizes because of his very good administrative skill. So thanks to Arvind. So Dr. Sathur, you aptly told that the topic is very important, non-critical yet critical, managing hyperglycemia in non-critical care setting. Now, the agenda of my topic will be divided into three parts: the guidance for the optimal management of hyperglycemia in non-critical care, what are the benefits of the newer analogs insulin in inpatient care, and my clinical experience with the newer insulin and hospital hyperglycemia control. Now, coming to the guidance for the optimal management of hyperglycemia in non-critical care, hyperglycemia is generally associated with an increased risk of mortality. The in-hospital mortality is of the tune of 16% in patients with the newly discovered hyperglycemia. With the patient with already known diabetes 3 and patient even with the normal glycemia, they continue to harbor an increased risk of 1.7% in hospital mortality. Now, the common thing comes to our mind whenever we want to treat the hyperglycemia in hospital settings. Only two things comes into our mind: whether we want to give the oral antidiabetic drugs, which are not generally recommended, or we give insulin to all and sundry, every patient who is in a non-critical care setting, and the way, the route of administration of the insulin, whether it should be IV or it should be subcutaneous. Naturally, the IV will be given in patients who are critical ill in the ICU, while the subcutaneous insulin is required in majority of the patients who are non-critically ill patients. Often we see that each and every hospital, nursing home, government, corporate hospital, the resident writes a sliding scale of the insulin because of the sake of convenience, because they don't have to get frequent calls from the nurse, how much insulin dose to be given. They write a sliding scale and the sister basically follow the sliding scale very religiously, and what happens? There is a roller coaster effect of the insulin sliding scale, because it is a non-physiological way of treating with retrospective reaction to the blood glucose levels. We are chasing the blood sugar, we are not controlling the blood sugar. And poorer glycemia control causes increased risk of hypo, hyper. So it leads to a roller coaster, cannot predict the insulin dosage requirement in the true sense. And it's not individualized also. It is sort of a reactive approach rather than a proactive approach. And we know the basal bolus regimen has stood the test of the time. Superior efficacy compared to this sliding scale of insulin. The best physiological way of glycemic control, and the ADA recommends use of basal bolus regimen in inpatient settings because it addresses three components: basal, the fasting in state insulin requirement; bolus for the mealtime insulin requirement; and correctional to give the unexpected glucose elevation or dispose of elevated hyperglycemia. Implementing basal bolus therapy to manage inpatient hyperglycemia in non-critically ill patient will improve the glycemic control, and we get very few hyperglycemic and the hypoglycemic episodes. The simple equation, how to divide the basal and the bolus dose, calculate the total dose depending upon the ideal body weight, whether the patient is having ideal or obese, or the patient is lean with renal compromise. So your total daily dose is anywhere between 0.4 unit, 0.5 unit, or 0.6 unit per kg body weight. When you are calculating the total daily dose, then you divide equally into the basal and the bolus. The 50% will be basal and 50% will be bolus. The bolus is then equally divided between the three major meals: breakfast, lunch, and dinner. And we write the instruction on the case sheet that sister measure the blood glucose 4 times a day, 3 pre-meals and 1 at bedtime before giving the basal insulin. Measure the insulin sensitivity. I will be coming later on. Based on the blood glucose measurement and the insulin sensitivity, add correctional insulin to the bolus insulin, and based on the fasting plasma glucose, titrate the basal insulin. Now, the Endocrine Society recommends that you divide the patient into usual category, insulin resistant category and the insulin sensitive category. The patient in the insulin sensitive category are those who are not able to take oral diet, or elderly patient, and those with the renal function impairment. The patient with the insulin resistance comes those who have persistent hyperglycemia more than 140, both in the fasting and pre-meal glucose, and those who are receiving corticosteroid, those who are obese. These are the patients who come under the insulin resistant category. The usual category of the patient belongs to the patient who are taking normal diet, the normal user. So this correction, what does we mean by correction of insulin? So whatever you have written the dose of the boluses before breakfast, lunch, and dinner, and suppose you do a pre-lunch blood sugar which comes to around 300. If the patient is insulin sensitive group, then you have to add a correction bolus of the 8 units, what I have written here. So depending upon the value of the blood sugar value, the chart has to be in front of the, in the case sheet, so the sister can give the correctional insulin dose in order to maintain the blood sugar throughout the day. Now, in hospital requirement, why the basal bolus? Ease of titration leads to effective glycemic control, lowers the risk of hypoglycemia, flexible and simple dosing, and uses in wide range of population. Now, coming to the benefits of the newer analog insulin and inpatient care, because most of the conventional insulin, the sister has to tell the patient to wait for half an hour or the 10 to 15 minutes prior when you are using the analog, as compared to the half an hour of the conventional insulin. Now, this is a very good chart where we have shown many RCTs, the randomized clinical control trial, which is the real world evidence. And all of them have shown consistent efficacy and hypoglycemia benefits with degludec in outpatients with type 2 diabetes. This is just to give a snapshot. Even if you are giving insulin as an outpatient, and when you compare with the comparator, like you are comparing the degludec with the glargine U100 or the glargine U300, or with the detemir or the NPH insulin, or you are switching the insulin between the degludec and the glargine. The blue arrows, they show the importance of the reduction in the fasting PP, the dose reduction, and the less incidence of the hypoglycemia. This mark shows that this is primarily mainly in insulin naive patient, the both, because the patient who are insulin naive, there was a significant reduction in the fasting plasma glucose and the significant reduction in the dose, while that was not true when we are comparing the basal bolus either with the use of degludec or with the use of glargine. Similarly, when you are switching the insulin from one brand to the another, from degludec to the glargine, in case it is showing that still there is a better fasting plasma reduction as compared to the other basal insulin. Let's see the important metrics of the basal insulin to be clarified in the inpatient. We know the insulin degludec has a rapid onset of action, 0.5 to 1.5 hour, as opposed to the glargine 100 2 to 4 and the glargine 300 2 to 6 hours. And it attains a steady state in a similar fashion compared to the other basal analog, and the steady state is achieved within 2 to 3 days as opposed to 2 to 4 or 3 to 4 days with the glargine 100 and U300. Now let's see, this was a trial which came this year only, 2021. The Galindo, they had a degludec hospital trial, which was a RCT randomized control trial comparing insulin degludec U100 with the glargine U100 for the inpatient management of type 2 diabetes. What they saw that degludec, which was titrated daily in both medical and surgical hospitalized non-critically patients, The mean blood glucose on day 1 itself was within the ADA recommended targets with the degludec, because it's a faster onset of action and there was no severe episode of hypoglycemia. Then came a observational study, which was way back in 2017. And this was basically from the Simeono group, efficacy and safety of insulin degludec for hyperglycemia management in non-critical hospitalized patients with diabetes. Previous one was a randomized control trial. This was an observational study, and the group of the patients which were basically recruited, 48% of the population were elderly population, patient 35% had CKD, and 23% were having PVD. And insulin degludec clearly demonstrated a good efficacy with very low risk of hypoglycemia. Only one nocturnal hypoglycemic episode occurred in the study. IDEORE studies, again, is a prospective observational study where the insulin glargine was switched onto the insulin degludec at the discretion of the clinician. The other group continued with the insulin degludec, while some patients, 20 out of 50 patients, were switched to the insulin degludec, and then it was followed in the group as insulin degludec only. And it shows lower hypoglycemia with the patient who are continuing with the degludec, and also in patients the glargine who were switched over to the degludec with the discretion of the physician, confirming the very low risk of hypoglycemia with the degludec. Apart from the low risk, the degludec has a better glycemic variabilities, a lower glycemic variabilities day to day in 24 hours period of time, even when you are comparing with the glargine U100 or the glargine U300. This was a wonderful study, the ONSET-1 study. The ONSET-1 study basically was study on the efficacy and safety of fast-acting insulin aspart in comparison with the insulin aspart. The faster aspart we are comparing with the insulin aspart in type 1 diabetes, a 52-week randomized treat to target phase 3 clinical trial. So this study was extended up to 52 weeks. And at 52 weeks, if you see the data, the overall glycemic control had significantly improved with faster aspart versus insulin aspart, consistent with the 26 weeks data, achieving an insulin profile closer to the physiological insulin secretion with the faster aspart translate into lower PPG and HbA1c level compared with those with the I aspart in people with type 1 diabetes, that is insulin aspart. So this was an eye-opener study, ONSET-1. And again, if you see the low risk of hypoglycemia with the faster aspart, significantly low risk of overall both daytime and the nocturnal hypoglycemia was observed with the FAST, that is fast-acting insulin aspart. And we have a flexibility of the fast-acting aspart while we're using in the inpatient, more convenient, reduces the risk of hypoglycemia, and in particular useful for the elderly patient with cognitive impairment and or irregular eating pattern, because this is the only insulin which can be given after the meal. Now coming to my experience with the newer insulin and the hospital hyperglycemia control. Here is a gentleman, 40 years old, who was admitted with the pyrexia of unknown origin, was being investigated, non-diabetic for past 8 years. He was already on 2 drugs with the maximum recommended doses with a antihypertension telmisartan. The blood sugar on admission was 150, A1C was 7.5, and the creatinine was 1.2, and the total count was elevated, maybe underlying some infection. The patient was started on what we call given the basal bolus insulin, like we started with the 6, 6, 4, 6 before breakfast, 6 before lunch, and 4 before dinner, with a bedtime degludec 16 unit. And this was the right hand side, the correction of insulin, depending on the blood sugar values. If you see now, the sugar were 180, 250, 160, 180. So on day one, with the sugar, we added the correctional dose of insulin. It came 4 units before lunch, made it 10 units. Then on the day 2, the sugars were like this. And in that case, we added, because it came to 220, then we reduced the dose by 2 units, made it 8 units, and continued with the rest of the doses. The day 3rd, we saw that in the day 3rd, with the 8, 6, 4, and 18, majority of the sugars were within the normal range, because we know the steady state is achieved within 1 or 3 doses. So this is a classical example of what we see in our patient and how we monitor blood sugar, how the sister enters the blood sugar values, and it gives a clear-cut pictorial view very easily that you are given the correctional doses and how you are adjusted the dose of insulin, and this is very important. So after, on day 5, the 24 blood glucose monitoring with the glucometer shows if fasting or the pre-breakfast 142, before lunch 126, before dinner 150, and after dinner 122, almost a very stable blood sugar. So to conclude my talk, the take-home message, the summary, that inpatient hyperglycemia is important to manage in day-to-day clinical setting when you are seeing the patient. And the newer insulin analogs come a ready reckoner in the sense that the patients in the hospital, the diet comes at a particular time. You cannot ask the patient to wait after giving the insulin. So the insulin analogs here comes as the convenient way to inject insulin just before the meal. And basal bolus is always preferred over the sliding scale insulin, but unfortunately, still majority of the doctors or the hospital, they still write sliding scale of insulin. And with the degludec on board, can be shown effective, safe, and can be titrated daily. Those we have many other basal insulin, but what I showed you some of the important steady state, the onset of action, and the hypoglycemic rates, which gives small edge over the glargine. And evidence has shown that insulin degludec cohort attained a mean VG, which was within the ADA recommended targets on the day 1 only. And the FAST, the faster aspart, is effective, safe, and offers post-meal flexibility. If the patient is not eating much, then you can give the insulin even after the meal, depending how much the patient has taken his meal. Thank you very much. So I'll be happy if the organizers are ready to ask any questions from the audience, or
Sir, can we take the question after? Can we take questions after the second lecture, sir?
Okay, as you like, no problem from my side.
Yeah, and thank you, Dr. Wangno, excellently summarized. I think the take-home message that you gave is so excellently said. Having used a longer-acting insulin like degludec, how many doses of boluses that you need, you determine that fairly well before you discharge the hospital in such a case. And judicious use of the meal-related along with the longer-acting is the most ideal way. Very well summarized, sir. And also, although many authorities consider and appeared in the Times of India and many newspapers that NPH is as good as any of the modern insulin, but you did show a couple of slides, the real world evidence, how better effectiveness, the fasting glucose, especially the nocturnal hypoglycemia, which are extremely common and can be fatal at times, are very well dealt if a patient can afford the modern insulin. Thank you, sir. And with that, we now come to the second lecture. And it's very nice to introduce Dr. Kalyan Kumar Gangopadhyay, has been an active in all the CMAs, very, very academically interested. He is also an MRCP and did the CCST in endocrinology. He's a senior consultant endocrinologist at C.K. Birla Hospital in Kolkata. So over to you, Dr. Gangopadhyay, who would be speaking on insulin initiation, where everyone dreads to think of the therapeutic inertia. I think this is a tremendous jigsaw or a very tight knot. And I'm sure Dr. Gangopadhyay would tell us how to go about the insulin and what would be the real world guidelines for practice in India. Over to you, Dr. Gangopadhyay.
Thank you very much, Dr. and Dr. Wangnu. I see you after a long while. We are all missing the physical meet well now. So I'm in the hospital now, so there are some internet. My apologies in advance. I'll see my slides. Hello, are my slides visible?
Yeah.
Yeah. Okay. Fine. So breaking barriers of insulin initiation in tune with the Indian patient needs. So I will tell you a little bit about the barriers we have, and at the end, I'll give you some real life examples of the patients that I have dealt with. So these are my financial disclosure slide. The agenda. We know about the fact that high PP levels, high carbohydrate diet, patients uncontrolled on multiple OADs, and the need for simplicity and convenience. We all know that. Now, I was we in each of carbohydrate whether it's south or central. Yeah. So 5% roughly, and if you compare that, it is much. Complications, we don't cardiovascular studies, but indirect tests and also soft evidence.
Is there a connectivity problem?
Dr. Gangopadhyay, we request you to kindly switch off your video and you can have a talk.
Yeah, yeah. There's a lot of disturbance. Yeah, that would be nice. You
Okay,
can switch your photo off. Yeah, video off. Yeah.
That I've done that. Can you see my slides now?
Yeah. It's fine now. It's fine now.
Okay. So, see, the indirect evidence with the high PPG and the macrovascular complications suggest that the PPG study, the HORN study, Honolulu Heart Program, Chicago study, all suggests that there is a relation between CVD and mortality. As far as microvascular complications are concerned, you have got evidence, just from southern India itself, with nephropathy, neuropathy, and retinopathy, all showing clear correlation with the PP sugar. So PP sugar is important for macro, microvascular complications, and it is more common in India. So that should be the background. And this is the old DECODE study, which suggests increase in mortality with high PPG. As far as the PPG contributing to the HbA1c, our picture is quite different from the Monier study. The Monier study suggested that with higher HbA1c, the fasting seems to be the main contributing factor. But here, for our Asian patients, the PPG is similar, if not more, contributing factor for maintaining the high HbA1c. So, across multiple studies, if we see the evidence from Indian studies, DiabCare, A1Chief, Present, Improve, you can see here the whooping gap between the fasting and the PP sugar and the high level of HbA1c that is there in our population. So what it tells us is HbA1c is high, needs control, PPG is high, we are more carbohydrate eaters. So anything that we do should be aimed towards tackling these. So barriers, so achieving glycemic goal by timely treatment optimization. This is an old slide that we start one tablet at a time, then the HbA1c goes down, goes up again, we add. Instead of that, it's now changed to multiple medications or insulin right at the beginning to get it down and stay down. So why is it important more for the Indians? And this is data comparing with the PIMA Indians who have a lot of insulin resistance. And you can see here, following a 75 grams OGTT, this blue is PIMA Indians and the orange is Indians. You will see the insulin level is much less, whether it is normal, impaired fasting, impaired glucose, or impaired fasting plus impaired glucose, or diabetes. So we are insulin deficient lot. We have got high PP, we eat more of carbohydrate. So that is what should drive our medications. Now, physician factors leading to therapeutic inertia. So these are all well known that about that we think that the patient might not adhere. We underestimate the patient's self-management skills. We underestimate the fact that if they are not literate, they cannot manage. And I've been caught out multiple number of times. Very intelligent people really making a mess of their insulin, and a person without any education at all managing it excellently. So don't judge the patient based on their education. That is my what I have learned over the number of years that I have been practicing. So one thing is not here, and we will never be here in any of the slides or any of the textbooks or any of the journals. What will not be there? The fear of losing the patient, because one fear is there that if I start the insulin, the patient might go away to another doctor. And that is a difficult question to tackle. And that is what all of us should be united, that if a patient comes to you saying that I've heard that you are the one who doesn't give insulin, so you must immediately rectify the patient that no, that is wrong. One who doesn't give insulin either doesn't know how to use the insulin or is not a good doctor. So that should be the unified voice in which we should talk to the patients. Otherwise, this fear will just delay the insulination of patients. So for the patient factors, what are the factors which lead to therapeutic inertia? They also have this lack of self-confidence. They feel that that they may not be able to do it. They feel that it will restrict their lifestyle. They have a different goal. They want to eliminate all the medications or reduce the medications. And of course, there is this financial burden. Now, again, in the textbooks, you will see there is a mention about weight gain being a barrier. But that is true for the Western population. In our country, when patients take insulin, yes, they do gain weight, but a handful of patients, and that also not too much. Yes, I agree, a small proportion of patients gain a lot of weight, but majority don't. That is not an issue. That is not a barrier. Hypoglycemia, I have read, very small number of patients use it as a barrier to start. They don't use it because they might have seen somebody have a hypoglycemia on insulin, that might trigger it. For majority of the patients, it is the injection pain, the fear that they have to take it lifelong, the financial burden, the fear that it will restrict their lifestyle and stop them from doing their regular activities. So when we want to start insulin for any patient, I make a list of these points and keep it in front of me. So before, I'm going to tell the patients that, look, it looks like you will now need insulin. Before the patient can open their mouth, I tell all these points in one go. So I address all these points, and then I tell, okay, now do you have to ask anything? He said, no, you have answered all the questions, all the queries that I have. So upfront, if you tell them about all the problems that they would anticipate, that makes it much easier, because the patients may say that I don't want to take insulin because of this one reason, but 3 reasons they will not tell you, because out of fear or out of respect or out of whatnot, but they will not tell you. But if you make a list of the problems that the patients would anticipate, and if you address them and tell them right at the beginning, that solves half of the problem. So begin discussion in a collaborative style. Discuss the health benefits rather than threatening. So we say, this, I'm going to give you an insulin which has won multiple Nobel Prizes. No other medicine has got more than 1 Nobel Prize. This has got multiple Nobel Prizes. I sometimes use the an example like this, that look, God gave us insulin. So at birth, nobody's born diabetic. It's when we exhaust God's given insulin that we become diabetic. So I'm going to give you back what God had given to you. So this is God's gift. I'm going to give it to you. Sometimes it works, sometimes it doesn't. You have to try every trick, but everything in a positive manner, not in a threatening manner, not that, look what you have done. This is what you would expect. You would expect that this treatment changes are a normal part of life. So I tell my patients, look, you have got glasses. Have you worn the same glasses for the last 30 years? No, it has changed. So just like that, with diabetes, this will also change. Emphasize the benefits of insulin therapy. This is the best way to convince them. Tell about the best benefits that you get with the insulin therapy. And then you could address the concerns. Many patients, I think once in about, say, 2 months, I end up injecting myself to show that it is not that painful. And that is a very good convincing point when I explain the insulin injection technique to the patients. So I think these are the main points that we do. Now, based on this, what should we start on? Just a brief thing. So, though the guidelines mention about basal insulin, and I would hasten to add that I also start many patients on basal insulin. Any insulin will get your HbA1c down. Any insulin. But what separates you, what separates the men from the boys, what makes you a better doctor is using the appropriate insulin for the patient in front of you. So you know that the PP sugar is going to be high. You know that the carbohydrate intake is going to be high. So you have to choose an insulin which will address that PP sugar surge. So the basal insulin, while it might be more suitable for the Caucasian counterpart, in our country, it will be successful in under 50% of the patients. So more than 50% of the patients, they won't succeed on the basal insulin. But I'm never saying that they never use the basal insulin. Basal insulin use is easy to use, easy for the doctors to use, easy for the patients to adjust. So I'm never saying that basal insulin throw away. No, but choose the type of insulin in front of you. For our population, it seems that the co-formulation, which has got the basal component plus the rapid acting component, is just suited for our type of patients, for Asian patients in general and Indians in particular. So because it has got direct control of the PP, and because it has got a very strong basal insulin, it also controls the fasting sugar. And the initiation is simple. You start with just 10 units. And the most important thing is the convenience. The patients feel that if I start insulin, I will be restricted in the lifestyle, but it's the convenience, and I will explain that to you in a minute. So do we have any real world evidence? This is the ARISE study, which was presented in August this year in the Australasian Diabetes Conference. This is people with type 2 diabetes initiating or switching to IDEG-ASP from any anti-hyperglycemic treatment. You can see in many countries, including India. So IDEG-ASP as per local practice. So whatever they were on, now change to IDEG-ASP. What happens? Observational study. So 58 years old and mean, and 13 years mean, age sign of 0.8. So why was it changed? It was not doctors were asked to change, they changed it themselves. The main factor, driving factor, was improving the glycemic control. And what did they use? Once daily majority. That is what I had initially stated to Novo when they first started with the Rhizodec. I said, you have started this drug. This is beautifully suited for once daily initiation. And that is what doctors are going to start. And that is what this study shows. You've got HbA1c down across all the countries, India 1.6 and maximum Saudi Arabia -2. So based on treatment, so those who were on oral tablets only and wasn't getting control, adding it dropped by 2. The important thing that before starting the treatment, whatever agent they were on, look at the reduction of the hypoglycemia. That's a bit surprising, I must say, because you have started insulin and the hypoglycemia has gone down with improvement of the HbA1c. That is quite surprising. Not only hypoglycemia, but severe hypoglycemia was also reduced, regardless of what we were on before. So here you can see premix and basal bolus, and you reduce the severe hypoglycemia significantly. And that has also resulted in reduction in resource utilization, hospital visits, emergency room visits, work days missed, all reduced. So you've got a 1.6% reduction in Indian patients with low risk of hypoglycemia, regardless of whatever medicines you were on. The last few slides, I will show you some real life studies. So the IDEG-ASP, I think, is an excellent choice for us because it targets the high carb diet, the high PPG level, need for convenience, and you have got multiple data to support its use. Now, in the eastern part, at least, I can't tell you about the rest of the country. In the eastern part, our diet is something like this. On a weekday, a working person will take a big bowl of rice. At lunchtime, it will be a small lunch, and dinner, you'll have roti. That's weekday. But during the Sunday, it all changes. Breakfast might be just a few biscuits, a little bit of puff rice, that's it. And lunch will be a big sumptuous bowl of rice again. So during weekday, you will have a surge of blood sugar levels post-breakfast, because that's when you have the bowl of rice. And during Sunday, you will have a big surge at lunchtime. So therefore, if you are using IDEG-ASP, it's perfectly suited. I tell the patients that writing the prescription, Monday to Saturday, take it before breakfast. Sunday, bracket holidays, take it before lunch. So that way the patient is happy that it is not inconveniencing them. It is tailoring it to their lifestyle, to the food that they are eating. So the couple of case examples, this was one patient with fasting 220 and BP 250. Clearly, this is ideal candidate for basal insulin, and I started basal insulin, but the sugar levels, she began to get hypoglycemic readings during the daytime. So my mistake was not taking proper diet history. That's my mistake. And I've learned from this. So when I did a CTMS on this lady, you will see here that during the daytime, the sugar levels aren't that high, but something happens after 9 o'clock, around 10 p.m., 11 p.m., it shoots really high. So when I asked the patient, why is it shooting up at night? She says, look, in the morning, I take a very small snack because my husband goes to office, my children go to school. Lunchtime, I eat really little amount of food. But at dinner, everybody comes home and we have a big meal. Now, I'm trying to address this by giving only a basal insulin. That is why, although the fasting is getting lower, but during the daytime, you're getting hypoglycemia. So I changed the basal insulin into IDEG-ASP, and that sorted it because you're tackling the postprandial rise because of the high carbohydrate at dinner time, and on top of that, you have the basal insulin as well. So another example of another person in whom a premixed insulin was used with breakfast and dinner. Now, what happened was the person is taking a very small breakfast, but a big lunch and a big dinner. So automatically, he is having hypoglycemic readings before lunch, but postprandial sugars are high. Again, the PK/PD of the IDA gas makes it suitable to use it twice a day, before lunch and before dinner. So you're addressing the PP surge here, and at the same time, you're reducing the hypoglycemia which occurred because you've given the insulin here. So I think in summary, our high carbohydrate, high PPG level, everything is to be taken into consideration when we prescribe an insulin. So I think I'm just on time, so I will stop now and hand it over back to Dr.
Yeah, thank you. Thank you, Dr. Gangopadhyay. An excellent analysis. I think what I loved most is on days, for example, like Sunday, you shifted the morning long-acting insulin to pre-lunch. I think this is a real good home message from your lecture. Once we say take insulin, we hardly give them any time and just keep on telling them, yeah, take at the same time. But I think your idea of getting involved with the patient and going deep into the diet history is extremely important when you put the patient on insulin, especially. I think that was a very good home point. With this, are there any questions? And let me take some questions for both the speakers. Let me see there. I don't see any questions. Can you see any questions, madam, there?
I think everybody has understood the topic so nicely by Dr. Gangopadhyay. So,
No, because both of you, both the lectures are complementary to each other, and both of you have spoken extremely well. So with that remarks, I conclude this session.
Thank you.
Has been to share this platform.
Thank you.
A lot.
Thank you. And Dr. Wangnu's output is perfect. It looks like the winter has set in.
You're right. Thank you.
Okay. Bye now. Bye.
Bye.
Bye.